So hi everyone. Pretty glad to be back in a sense. I've been wanting to do this for a while, and I really managed to get my schedule in order last year. Plus, pandemic, getting a kid, ICU, great combination. In any case, this presentation should be a easy review, and then hopefully for the rest of the year, I'll have some more in-depth and more critical care stuff to present. Very happy about the title. I'll just tap myself on the back for that one. So for the people that don't know me, I am a 5-year grad from last year, and I decided to do a 2-year fellowship in ICU at University of Montréal. So I've been living in Franglish for the past year, and if I make some weird grammatical errors, my apologies. So I have no conflicts to declare. Objectives basically is to recognize critical from non-critical hypertension. I'm using terminology that's maybe a little bit different from the textbooks, and I'll explain why. Understand the different contributors of blood pressure, list the different treatment options, and to begin and titrate adequate management for patients with critical hypertension and various causes. So far, so good. So we are going to talk about physiology, non-critical hypertension, critical hypertension, a little foray into pharmacology, and then end with management and take home, which is quite convenient because most of you are already home. I already prepared that joke. Thank you. Just to talk directly about why I'm using non-critical hypertension and critical hypertension as opposed to the classic definitions, is that I don't feel that they rightfully represent the reality of emerge or critical care. When I see a patient in front of me that has organ injuries that's associated with hypertension, I honestly don't necessarily care that much if he falls into the primary hypertension or the secondary hypertension category. So I just want to know, do I have to do something about it, or is this something that could be dealt in an outpatient basis? So the classic definitions that you'll find in the textbooks, there's primary hypertension, which is basically kind of like the old school term essential hypertension, basically the hypertension that most people are walking around the street with. Secondary is basically caused by a pathological condition, whether it's renal artery stenosis or the good old zebra pheochromocytoma. Hypertensive urgency is an outdated term, do not use, and I'm not even going to describe it because it's being thrown out the window as it should. And then hypertensive emergency, which is kind of the same thing as what I would describe as critical hypertension. It's basically when you have, in a simplified way, an acute organ injury. I don't care if the patient has CKD, right, from his hypertension from years of high blood pressure. It has to be an acute organ injury and associated with hypertension. It doesn't matter if the hypertension caused it, like hypertensive encephalopathy, flash pulmonary edema, or hypertension is a result of an initial process like a stroke. What I'm trying to simplify this concept to is that there is an organ that is suffering and the hypertension is associated with it, and we need to deal with it. It's causing harm. So let's move forward to physiology. I'm in ICU. I have to add an equation because that's what we do. We just make a lot of things boring. Why do we care so much about blood pressure as a whole? Never mind hypertension. Why do we care so much about blood pressure? So, I mean, a minimalistic view of ICU medicine, emergency medicine is just making sure that oxygen reaches mitochondria at some point. But there's no real easy way to measure that so far. So we use an array of imperfect clinical information, vitals, physical exam, ultrasound, labs, as a proxy for mitochondrial well-being. Blood pressure is one of them. And we know that extremes of blood pressure, low blood pressure, high blood pressure, are bad, right? Too little oxygen doesn't get transported, or too much and the pressure starts overtaking the heart, damaging the vascular network, and just causing havoc on your organs. Now, the reason why I'm putting up a boring equation is just to help you think about the components of blood pressure and help us think, well, where's the problem and what are the targets that we can go after? So basically, your MAP, or your mean arterial pressure, is a function of cardiac output and your systemic vascular resistance. And then we all know the cardiac output is your heart rate times your stroke volume, and then your stroke volume is basically a function of these four items. Obviously, rhythm is not going to play that much role in a hypertensive crisis, but the other three are going to be quite important. And so when you realize that blood pressure is basically a component of all these things, then it gives you an idea of, well, what are the targets to go after? Now, I realize that, you know, not all of these pharmaceutical aids are going to be useful in a critical setting. So really what we're left with, because, you know, I'm not going to use DIG to lower blood pressure. I'm not going to use cholinergics to lower blood pressure. What we're left with is mostly beta blockers, calcium channel blockers, and nitric oxide dose. I mean, there are others, obviously, but this is really our tool basket. Not to forget that acutely, a big component of elevated blood pressures has to do with pain, has to do with anxiety, and then there are some other medications that will obviously have a huge impact on the blood pressure itself when we're intubating patients, for example. So just to keep that in mind. So hopefully the physiology part wasn't too painful, and we'll just move towards non-critical hypertension. So non-critical hypertension is basically, just to give you you know, more of a scenario, is basically the person that's coming in from the clinic, from a pharmacy, or even from home because they have a BP machine at home, and they're coming in because of a high number and a high number only. That's it. Hey doc, my blood pressure is through the roof, do something about it. So again, to simplify, these patients with asymptomatic hypertension, no matter what the number is, that evaluation, that treatment shouldn't be done in the emergency department. And the reason is it's very unlikely for a blood pressure to rocket skywards in a matter of a couple of hours and the patient to remain completely asymptomatic, right? If that blood pressure rise, dramatic blood pressure rise is acute, usually it's because there's a critical underlying cause or a huge amount of pain, anxiety, or maybe even the measurement's wrong. But otherwise, hypertension is a chronic process. It doesn't just appear from one day to the next. So asymptomatic really is the key here. And by symptomatic, we mean that there's no acute organ damage. And that's what the AHA guidelines, and that's what Rosen says. So more recent 2017 AHA guidelines basically centers around the same point, is that you know, if you have a patient coming in with a very elevated high blood pressure, here they use a number, but numbers aren't as important. It's hypertension plus or minus organ damage. If you don't, then the patient, there's still something that you can do for the patient, but it's not going to be in the emerge. So you'll notice the guidelines mention numbers, but I don't. Patients with chronic hypertension have very high numbers and no organ damage because they've adjusted their autoregulation. They can tolerate these numbers. On the other hand, patients who are normotensive or even have low blood pressure at baseline, let's say, I don't know, pregnant patients, can have organ damage at numbers that would seem very unimpressive. So that's why I don't think the numbers matter as much as understanding the patient in front of you, right? Also to note, acuity is important. What I was saying about the rise, right? If you increase your blood pressure by 200 in the space of a few minutes, and you're otherwise a normal patient with with a normal blood pressure at baseline, then yeah, that acuity is very important. But if you're a chronic hypertensive patient that's been living with blood pressures at 180 for the past couple of months, if not years, then your body has had time to accommodate, and it's really not going to cause that much damage short term. We all understand that hypertension long term is a problem, but that's not the focus of this presentation. Little note also is that they don't mention MAP, which is maybe one of the numbers that translates most to the damage that is perceived by organs. Obviously, specific situations are different. I think everyone here is thinking of dissection, but as far as organs are concerned, for encephalopathy, for example, the MAP is maybe the thing that is more representative and maybe the target to go after. So acute organ damage, what are we talking about? So we're talking about brain, we're talking about heart, we're talking about vessels, kidneys, microvasculature, and others. Things like epistaxis, a mild headache, or non-specific symptoms that the patient might come with are very unlikely related to their high blood pressure. And it's not what I would call as a symptomatic cause of their hypertension, and therefore they would fall into the hypertensive emergency category. No, so the patient comes in with a high number and a mild headache. Obviously, do your due diligence and make sure there's nothing dangerous, but otherwise, they're still in like a non-critical hypertensive type of category. So far, so good. So I'm saying a lot of things that, we don't need to do this, we don't need to do this, but what can we do for them, right? So again, looking at a blown up view of the guidelines, there's nothing that says admit, and nothing that says investigate, and that's true. No guidelines recommend routine testing in the ER. There's actually a study in the American Journal of Emergency Medicine in 2010 that looked at patients exactly in this situation with hypertension, no acute organ damage. Do we do routine testing or not? So the routine testing identified abnormalities in about 6% of those patients, and none of these abnormalities were directly linked to hypertension. So there's no point really. So no testing. Okay, so what are we actually going to do for them then? It depends. So it's, to me, I'll kind of split them up into patients that are known hypertensives and then a new diagnosis, patient that didn't know they had hypertension and come in with a blood pressure in the 180s. So my take is, like I said, no investigations. For the patients that are known hypertensive that weren't taking their meds or something like that, then you restart them or you re-prescribe them. You make sure that the patient has follow-up, and that's absolutely key. And educate the patient, maybe educate the pharmacist that sent them over, maybe educate the primary MD. So those would be the four things that I would focus on to do for these patients. Now, the guidelines do mention that we should consider prescribing a first or a new antihypertensive for these patients. I have my own qualms with that, and I know that some MDs are very comfortable with doing that and have a lot of experience doing that, and kudos to them. I'm just not a fan of starting meds in the ED, because usually the ED is a situation that is not really representative of their baseline at home. Maybe they're under stress, pain, white coat syndrome. Maybe there's some new meds in the background like steroids or NSAIDs that can increase their blood pressure. Maybe you decide that you want to start some meds like an ACE, an ARB, calcium channel blockers, beta blockers, thiazides, but maybe the primary MD has a different choice than you do, and they're the ones that are going to follow them. And also importantly, there's no harm in not treating those patients. There was a study in JAMA 2016 of 58,000 patients and divided them into treatment and no treatment, and there is no outcome difference at 6 months. So you can, I mean, if it really satisfies the patient, but there's nothing that's holding you to absolutely prescribe new antihypertensives for patients with coming with hypertension but that are asymptomatic. So that's my take on that. Now, critical hypertension. So again, to simplify, these are patients with acute organ damage and hypertension. They're patients that are actively being harmed by their elevated blood pressure and need an immediate blood pressure reduction. So, well, what are we aiming for then? Do we reduce by 20 of systolic? Do we reduce by 15 of diastolic? Do we reduce by a percentage of MAP? So what do we do? It's divided into really a general management and specific management. So specific conditions that will require very specific targets, and most other situations that you would kind of call more like the more classic, primary hypertensive encephalopathy or primary hypertensive emergency, that kind of respond to all the same treatment, maybe not the same meds, but the same targets. So if we're talking about targets, then what's allowing us to aim? How are we aiming, right? So there's our automatic trusty BP cuffs. How they work is basically they measure a MAP, and then only after there's an algorithm that calculates the systolic and diastolic. So really the most precise measurement from these BP cuffs is really the MAP. Also, I was always under the understanding that, not having the correct cuff size is going to cause some dramatic error. And there's actually this nifty paper, oldie but a goodie, in 1991, that looked at the effect of a cuff size 1 too large or a cuff size 1 too small. And basically the differences are really minimal, like 5 millimeters of mercury for systolic and diastolic. So not the end of the world. As far as manual blood pressure, it's actually not as accurate as automatic BP cuffs. So if you're not happy with the blood pressure that your cuff gave you, manual is not going to get you a better answer. So honestly, stick to BP cuffs. And then in certain centers, we can go straight to art lines. It's not as easy as just like, oh, okay, we'll just do art lines and that's it, right? You need the entire department to be on board, your nurses, your staff, and the people that are going to receive them also have to be on board a little bit. The advantage is that obviously it's real-time BP measurement, particularly useful in cardiac arrest, for example, or if I'm going to intubate someone with an intracerebral hemorrhage, I'd like to know what my intubation is going to do to that patient's blood pressure, because it's pretty key. Sorry, I'm looking at chats and I'm not seeing the chat, so maybe I should turn on the chat and see what happens. Who's trying to talk to me? Ah, yes. Sorry, a bunch of comments, which I'll get to a little bit later. Sorry, Monica. Where is that? Yes, art lines. So it has its uses, but you need to be able to troubleshoot it. If is your art line damped? Is your art line resonating? Or is it giving you a right measurement? Although MAP is usually going to be accurate. And a lot of people saying that it never really saved anyone, and there's no prospective studies that show that art lines are beneficial. And I agree with that. So it's really it's a tool that's not necessarily, not completely necessary for all conditions. And especially you'll see later that the targets the guidelines mention are not that, they're not that evidence-based. A lot of these targets are basically expert opinions. So why, it's kind of like a circular argument, is why try to get an absolutely precise measurement when the targets that are asked are kind of fuzzy, right? We all understand that these blood pressures need to be decreased, but the actual numbers and the precision of it is not that clear. So why do an art line when you don't really need that precise of a measurement in the first place? I'm being the advocate, like a devil's advocate. I see you and emerge. I like art lines, but it's not for everybody. So, and then how are we treating? Which forays into pharmacology? So pharmacology is basically the slide that I had before that was a little bit busy, and that I will hopefully simplify by a wonderful table. I'm just going to name a few agents that are going to be the bread and butter of hypertensive management, and then I guess let us know in the comments if whether you have these agents in your institutions and what you like using. So as far as calcium channel blockers, so if you remember your 3 different classes of calcium channel blockers, the dihydropyridines are really the workhorse for blood pressure management, because they're really going to be more arterial vasodilators as opposed to the other 2 classes, which have maybe more of a heart targeting. So nicardipine is particularly used in neuro patients. I know that we use it a lot at the SHIM. Fairly quick onset. Duration is kind of borderline. So it, as far as a titrating agent, it's not perfect, right? Because you'll understand that a clinical situation can change quite a bit in 1 to 2 hours, and so the dose that is being given in perfusion might need to be changed, but because the duration is 2 hours, it might accumulate a little bit. Not as much as obviously as agents that last 6 hours, but still. So it's a quasi titratable agent. Liver metabolism, so avoiding cirrhosis, and particularly used in neuro patients. Clofidipine is basically a shorter acting nicardipine, and it's fantastic. I don't know. I know that it's not really widely available. The only place on the French side that uses it is the SHIM. I'm not sure Sacré-Cœur has it. And even then, it's you need to have a good reason to use it because it's quite expensive. Theoretically, not to be used with patients with egg and soy allergy, but this is only in vitro data. So that's our calcium channel blockers. Nicardipine is kind of quasi titratable. Clofidipine is really titratable and quite a useful agent. The beta blockers, esmolol, which I particularly like, esmolol, which is mostly a beta 1. So it decreases your blood pressure by decreasing your cardiac output, right? So to maybe not the greatest for neuro patients, right? But otherwise for certain cardiac presentations like dissection, fantastic. Labetalol, obviously the duration is quote unquote problematic. It's hard to titrate down, but I do appreciate it because it's so easily available. It's one of the quickest things that you can actually get from your nurses, and it's absolutely great as a bolus agent. Because fine, it's hard to titrate down, but you can still titrate up, right? And so that's exactly how it's meant to be used. You give a bolus of 10, you see the impact fairly quickly. Are you happy or are you not happy? If you're not, then you double your dose. You go to 20. Are you happy or you're not? You go to 40, up to 300 in a day, I believe. So quite useful before you can get other things on board. As far as the nitric oxide donors, nitroglycerin really is the workhorse of that category. A truly titratable agent, very useful. Obviously, to be careful in RV failures, in people on Cialis, Viagra. It can cause some reflex tachycardia, so it's quite lovely to use with beta blockers. And then the theoretical, I wouldn't say contraindication, but is that it causes great systemic vasodilation, but more so than in the cerebral circulation. And so what happens is that there is a kind of a little bit of a neurological hypoperfusion. So less of a great agent again in neuro. Its other cousin, nitroprusside, which is truly titratable, but still, even though like the onset and duration are quite short, it's still difficult to titrate. It still has some white swings sometimes. And then it comes with the issues of creating some lactic acidosis, which is a problem in critical care patients when you don't know where what your lactic acidosis is from. The cyanide toxicity, obviously, but it's really if you use it at like a pretty high dose and for multiple hours. I mean, not to be ignored, but you know, a lot of people make a big deal out of it. There is such a thing as coronary steal from it. So some of the healthy coronaries will dilate more than the non-healthy coronaries, and therefore the ischemic parts of the heart will get even less perfused. So not great in MI patients or CAD patients. And then some reflex tachycardia, which obviously happens a lot in vasodilators. So maybe not that great. I think nitroglycerin is a perfectly good agent, and some might argue that it's more of a venodilator, but at a high enough dose, and people very often underdose their nitroglycerin. They're too afraid to go high. At a high enough dose, and I forget exactly which one it is, maybe Sophie will be able to help it. It becomes an arterial dilator, so no problem with that. And then others that are used sometimes, enalapril, I've never really used it, and I have absolutely no experience with it. You look at the duration, it's terrible to titrate. Hydralazine has a very unpredictable effect. So again, these two agents are not great. It's stuff that you'll still hear, but not really useful. So really, those are the tools to use. And really, the clofidipine, esmolol, nitroglycerin are really going to be the ones that are fully titratable and great to use in critical situations. Nitroprusside is titratable, but if you have nitroglycerin, then that's what I would use preferably. I didn't put any dosages because we live in the 21st century, and we have great apps. This is one of them, Easy Drips, and I absolutely adore it. I use it frequently, and I highly recommend that you all use it. Okay, now I'm getting some questions, and I've been ignoring you guys, and I'm very sorry. So I'm going to take a minute to look at the chat and answer questions because I'm not used to doing this. Okay, so with regards to investigations, the question from Monica with renal dysfunction and Annalie to do an EKG. You can, it's like you commented, it's cheap and quick. I perfectly agree. And that's where, but you know, we know from very large studies that no significant bad outcomes happen to these patients that are asymptomatic. So, I mean, it's up to you. I think the most important is going to be the follow-up. These patients can't just go into the ether and not get any follow-up, where these things will eventually be picked up. Now, obviously, if follow-up is a problem, then maybe that's when I would consider doing some of these cheap and easy investigations just to get maybe things started and maybe help out whoever is going to do the temporary follow-up. But again, there's no right or wrong answer. You're protected either way. Use catapress. I'm not sure what that is. Maybe. Well, lots of conversation. This is fun. Yeah, clonidine. It depends. Clonidine, I've used it in ICU mostly for patients that are kind of coming off of their Precedex, dexmedetomidine, and really benefited from it, and find you want to get a little bit of the blood pressure control, but also maybe a little bit of not sedation, but kind of like anxiolysis, I guess. So I use clonidine in that spectrum, but clonidine at home can be kind of annoying in a sense, because patients who are on clonidine at home and go into withdrawal can go into really, really bad hypertensive crisis. So not the biggest fan of clonidine at home. I've never really used clonidine that much as like as a titratable agent or as an agent to use in a hypertensive crisis. With the agents that I just mentioned, you'll be able to cover the grand majority of issues, and then for other, like for specific management, specific cases, they'll to treat with calcium channel blockers, beta blockers, and nitroglycerin. Any other questions?
Ollie, just so you know, you have left.
Sorry, I didn't hear you.
Just so you know, you have just a few minutes left.
Few minutes. What's a few minutes? Is that 1 or 20?
You have 5 max.
5 max, sounds good. All right, so we'll go into management, which is good because it's the last part of my talk. Again, what are we aiming for? So I kind of divided into, you know, every critical hypertension, and then certain conditions that require very specific management in specific conditions. The 2017 AHA guidelines talk about reducing your blood pressure by a max of 25% over the first hour. Where does that come from? It's basically that if you remember your autoregulation curve, yay, the cerebral vasculature maintains a steady perfusion through a range of MAP, right? The thought is that the lower inflection point on the autoregulation curve is the point that's the point where the brain becomes hyperperfused. That point is 25% below your steady state MAP, whatever that MAP is, right? So they say if you reduce it by 25, you're going to be at the lower inflection point, and then you'll become hyperperfused. But that doesn't really, that works in a steady state. But when these patients come into the emerge with their blood pressure sky high and organ injury, they're not in their steady state. So I don't see how their lower inflection point is 25% away from where they are right now in the emerge. Because we don't know where their autoregulation curve is and where they are on that when they come into the emerge. So it's a class 1 recommendation, fine, but it's an expert opinion. And basically what I mean is, these patients require a rapid MAP decrease in the first hour, no doubt about it. You should titrate therapy to the patient's symptoms. So if it's 10% of their incoming, their initial MAP, then great. But some may need more than 25%. And there are some studies looking at, I forget which one it was, but it was mostly in cardiac patients, that they did very well with a decrease in 30 and 40% decrease in MAP with no significant negative outcomes. Once you've reached that target in 1 hour, you continue to reduce progressively over the next 2 to 6. The AHA target mentioned basically an equivalent MAP of 120. And then after that, over the next couple of days, you continue reducing and try to smooth them into a relatively normal hypertension. So that was for the general management, the targets to reach. As far as the medications to use, nitro is great for basically your cardiac patients. Beta blockers maybe to be avoided a little bit because they'll decrease your cardiac output. And then for everything else, it's whatever you're comfortable with, to be honest. There are no studies that shows one is better than the other. Aortic dissection is basically decreasing the DPDT, basically the shearing force, right? The whole point is to, here's the point, decrease the height of the pressure wave and try to spread it over a longer period of time, right? It's decreasing the acceleration of each pressure wave so as not to further the dissecting injury. So we have to decrease the heart rate, we have to decrease the stroke volume, we have to decrease the systemic vascular resistance. So the greatest combo is going to be beta blockers and vasodilators. Here, the specific goals are much shorter. We really need to act very fast and try to decrease the heart rate first, and then eventually your systolic blood pressure in the areas of really closer to 100. And so that's best done with beta blockers and vasodilators, right? And you'll see on the graph there how it impacts that DPDT. Right, don't forget pain control. These patients are in a lot of pain and it has a very high adrenergic drive. So pain control for these patients quite a lot. Brain bleeds. Basically, most of our knowledge of blood pressure control in these patients comes from 2 trials, the INTERACT-2 and the ATTACH-2 trials. And basically, we sum it up by saying that we should aim roughly at 140 in an hour. That was the trial design, although it wasn't really followed that well during the trial. So our best guess is that that's what we should aim for, to reduce the bleed, but also to make sure that the patient's still well perfused. The best or I shouldn't say the best, but the most studied drug in this population is nicardipine. But apart from the vasodilators, I'm sure others would be okay as well. There's no paper that says that you can't use beta blockers, although theoretically it could maybe hyperperfuse them, but you have your patient in front of you and you have your institution with the drugs available to you. You have to make a decision. For subarachnoids, the guidelines aren't super clear. They kind of hint at aiming towards 160, but there's no clear target to reach from the stroke guidelines. In the 2017 guidelines, again, well, and then there's the recent ICAS-3 reanalysis, which maybe will get us away from using TPA. But if you are going to use TPA in stroke patients, your targets before you use the drug should be, you have to treat if they're over 185, over 110, and then maintain them 5 below that for the next 24 hours. If you don't use TPA, then just make sure that they're not above 220 over 120, and you aim for a 15% reduction. Again, nicardipine, labetalol used more frequently, and avoiding nitric oxide donors in those situations. For the patients that are kind of in between, data says that those patients weren't harmed by very high blood pressures, and maybe it helped them perfuse their brain a little bit better. So you leave them at that. Preeclampsia, from guidelines from 2 years ago, they use a bit different drugs because it needs to be compatible with the fetus. So nifedipine is a good drug to titrate up. It's an oral agent, so obviously in your patients that are confused or seizing, then maybe not the greatest, in which case I would go for labetalol and then just basically titrate up bolus doses. Hydralazine, again, unpredictable drug, I would stay away from it. And then your second line agents, of all of those, much bigger fan of nitroglycerin if I'm in a rut, and then maybe consider labetalol if I wasn't using that initially. Your goals is basically to stay under 160 over 110 for your severe, but you still treat your non-severe preeclamptic or non-severe hypertensive pregnant patients anyways, and that's at a goal of 140. So basically treat the severe ones and call your friendly OB gynecologist to figure out what your targets are going to be in your institution. A lot of people think of magnesium as a blood pressure lowering agent. It is as a vasodilator in a sense, but that's not why it's used in this situation. Here it's really to prevent cerebral ischemia and seizures. It's just an added bonus that it drops BP, but I wouldn't use it as a BP lowering agent first and foremost. Voila. Take home messages that you can all read, and glad to be back. Questions, comments, insults?
Great, thanks very much, Olivier. If nobody has any more questions on the side, doesn't look like it. Thanks very much. We can move on to our last talk of the day, which is Ahmed, who will be presenting his grand rounds. Thanks very much again, Ali.